Ngā mihi nui kia koutou, tēnā koutou katoa. So greetings everybody. I work now at Counties Manukau Health for the next 11 months or so, until we cease to exist, I guess, at Kids First Hospital and at the Population Health Directorate, and I have honorary appointments for my university research. Anybody from Australia here who managed to sneak across from that bubble just burst? Okay. This presentation is a nod to our colleagues across the Tasman, and I am presenting it in relation to a project I'm engaged with them on, but also because I hope these data, which relate to the Victorian state, have implications for us, and I hope that the question time will potentially particularly reflect on what we can take from this. So I want to acknowledge my co-authors, who are all part of the team called Restore. The rationale for this particular study is basically the fact that we don't know in most rich countries, high-income countries like Australia and New Zealand, fortunately, child injury mortality has been coming down thanks to the good work of many of you, really. But what we don't know is really for those who survive serious trauma, are the risks of long-term problems changing? Are they increasing? When more seriously injured people are surviving, what are the long-term impacts? They could be getting worse, or they could be getting better, or they could be staying the same. We really have very little information on that. And there is where studies have been undertaken overseas, they've been mostly sort of trauma center-based studies. They're not population-based. They're often followed up only for about a year. That's a long-term study as far as many of the injury outcome studies, especially in children. And even in those studies that have gone for more than 1 year, there's no tracking over a period of time. They might have done them at sort of a 2-year follow-up. Follow-up rates are often quite low. And this is somewhat different from what tends to happen for adult injury outcomes, where there's a lot more attention to have adults got back to their normal well-being, and that's partly because you want them back at work and you want them not costing the insurance providers that much. Kids, there are also issues in terms of the kinds of outcome measures you might want to use, because it's not good enough to get a 5-year-old back to where they were at 5 when they're now 6 or 7. So the measures that we use have more complexity as well. So there's a lot of reasons why the child trauma outcomes topic has really not got the attention adult services have had. We have very little information on early predictors of what long-term outcomes in child trauma might look like. I'm particularly talking about major trauma here. So these gaps in evidence globally are really challenging the kinds of services that you might provide or wish we all did to really address issues across the continuum of trauma care, not just getting them to the hospital or getting them fixed and well enough to leave the hospital, what happens down the track. And I think that's really a major challenge, because often many of the services you might represent probably lose track of them as well. So Restore, which is the project that I'm part of, actually not much flying happening between these countries that are collaborating at the moment, but it's basically a study based in the Victorian state, but there are collaborators from the UK, and I am the collaborator from New Zealand, not because there's New Zealand data here, but because I'm actually contributing to their pediatric trauma outcomes information. The aims of this study, it's a population-based prospective study of children defined here under 18 years of age with major trauma. And the intention was to investigate patterns of recovery over a 5-year period, consistently and systematically in all children who had major trauma in the state of Victoria, and to identify predictors of good recovery. So the participants were all Victorian children who had major trauma, registered with the Victorian State Trauma Registry. And this is an opt-out registry, so you really have to say, no, I don't want to be a part of this follow-up. In fact, most caregivers, parents like their children to be followed up and know that things are tracking the way they should. The injuries that we're looking at all occurred in a 1-year period in 2011 to 2012, and the category called major trauma in this registry, ISS over 12, injury severity score over 12, or they were admitted to an ICU for at least 24 hours and required either ventilation or surgery during that ICU admission. That's the definition of major trauma for the Victorian VSTR. Follow-up was at 6 months, 24 months, 36, 48, and 60 months. And most of the data that I'm presenting were data reported by caregivers, predominantly parents, on behalf of children or young people. These are the outcome measures. I won't go into the detail. These are quite standard outcome measures that are used in injury studies. And I guess the only thing I want to say is the KOSCHI, which is actually originally developed as an outcome measure for head injury outcomes, is now used quite widely for major trauma. And the Glasgow Outcome Scale extended score was used for the 16, 17-year-olds, and those can be cross-mapped. So we can actually use the KOSCHI as the main outcome that's going to indicate recovery. I'll give you that data. We had, in the course of that year, where the actual recruitment happened, less than 200 patients who basically participated. There were 13 of those children who died in that admission. And most of the trauma patients in this are not going to surprise you. 2/3 were male. Socioeconomic status actually was across, low income for 42%, medium for 40%, and high income a bit less. 63% were from major cities, predominantly Melbourne and other outlying satellite cities. Injury severity score over 12 for 86%, so the others were basically ones who had been at ICU. The kind of other things, 50% were due to road trauma, not a big surprise. 50% had a traumatic brain injury, also not a surprise for this major trauma category. Just one thing to note, this particular registry does not collect ethnicity data, and all the outcome data was collected in the English language. That is something we need to bear in mind in terms of the transferability or comfort we would have in that approach. I think we would be doing it differently here. Follow-up, 6 months, actually they're very good follow-up rates for a trauma outcome study. Basically, by 5 years, 71% of these patients were still being followed up. Non-responders were more likely to have had a road crash, had compensable injury in the Australian setting, and had a prior psychiatric history. This is one of the main findings. So this is the KOSCHI result. And what you're seeing here, if I can, do we have a, have you got an arrow sort of thing? No, it's all right, don't worry. Light blue is effectively the intact recovery, where the KOSCHI said full recovery was achieved. So that you can see that proportion is going up all the way to 5 years. The next blue line is good recovery, but there were some residual impairments attributed to the injury, and that's also tracking upwards. The light green and dark green are moderate, severe to severe, moderate injuries. They're all moderate disability, I beg your pardon. And the colors over that are basically much more severe disability, or in the case of the black small bars, those are deaths that happen in that follow-up period. What's striking here is that all the way up to 5 years, there is some movement happening. But even at 5 years, only 40% had full recovery. And if you looked at full and good recovery, where some residual impairments were still there, 60%, which meant 40% of children have at least moderate degrees of disability, if not worse. This is flipping things around, where the light blue is actually the recovery group, and they're at the top end now, and the dark colors are basically indicating where there's more significant disability going on. It's basically showing 2 slides. The first one, looking at the light blue, is presenting full recovery, and the second slide, the light blue, is presenting full or good recovery. But what's really being shown here is that even from each of these time points, there's a bit of flip-flopping going on. Some children who at 6 months had fully recovered, when they were reassessed at 12 months, a proportion of them had gone backwards. And that kind of pattern is not surprising. So the kids are overall trending in the right direction, but there is a bit of flip-flopping going on in terms of the types of degrees of recovery. And so it's a very sort of transitional period where things can be moving quite a bit. This is showing the PEDS-QOL, which is more health-related quality of life measure, used quite commonly in injury outcome studies. And what's most important to recognize here is over that same period, a higher score, by the way, means better quality of life. Both the physical quality of life, the psychosocial quality of life or the total quality of life, and the EQ5D, which is a utility measure which is used for cost effectiveness analyses, they all tracked in the direction we would like. That is, the mean of those quality of life measures were improving to a point where the physical quality of life mean actually approximated the national norm for Australia by 5 years. But obviously there's a proportion then who are not there yet. What is also important is that that difference between 6 months to 60 months, that those figured changes are clinically meaningful differences. The 4.5 kind of level of increase is a clinically meaningful difference in terms of those measures. As predictors, there's very kind of detailed confidence intervals that I'm not presenting here, but just as a broad brushstroke, the predictors of adverse outcomes, that is not good recovery, were basically for some of the scales being female, being older, low socioeconomic status almost across the board for all the measures, regional children who were injured and mostly treated in regional hospitals as opposed to the major trauma hospitals in the city, comorbidities present versus not, and compensable versus non-compensable injuries, intentional injuries rather than not, and non-road crashes rather than road crashes. There is an important issue here. The road crash injuries are covered by TAC, the Transport Accident Commission in Victoria, so they do get a bit of a Rolls-Royce service in terms of post-crash support systems. And head injury was obviously another major predictor of adverse outcomes. So what are the implications here? And I'm partly referring to the implications overall for Australia, but really for the international space here, because these types of studies are as rare as hen's teeth. In fact, we could find no other study that has tracked major trauma for this period of time. So I think the main findings are, we know that things are improving overall over a 5-year period. So a lot of people say things won't change very much after 12 months. Not true. But even at 5 years, we have substantial levels of disability, and we have to be really concerned about these kids and how much in view they are to any services at all. And there are readily identifiable demographic characteristics and injury-related characteristics that predict poorer outcomes, which leave us opportunities to intervene early and potentially avoid those inequities. There's a real need to understand what children's perspectives are. I think that they're far less engaged in studies to look at what they believe their experiences are, how they navigate difficulties, what their sources of resilience are. And we need to obviously examine the kind of barriers, both environmental, the physical, social, healthcare barriers that might be there, as well as institutional structures, including, for example, in New Zealand, the extent to which ACC is available for everybody. And obviously, there's much to do with regard to the actual structural determinants, the social determinants of injury occurrence in the first place, and then they play out across the whole continuum of care, i.e. poverty and access to, reduced access to all sorts of amenities and services. And we then really need for New Zealand to consider the kinds of service models that can ensure these sorts of issues. If we did do a study like this, and I probably don't think we need to do a major study to understand these are not issues unique to Victoria. What kind of service models will be helpful to avoid the kinds of inequities that we are very likely to see, particularly around ethnicity? I think you will be not surprised to know that if we know that the injury occurrence is much higher, as we've heard many times from Maori and Pacific, low-income families, well, the outcomes are not going to be terribly different. Interestingly, there is some preliminary unpublished data to say, however, they cost ACC less, which means they might be actually getting ACC services less. So there are really important opportunities, I think, with more regionalized services, as happens in the way services are provided for major trauma, and the health system restructure. It really is a time to consider what the best model of care would be for pediatric major trauma to have the best possible outcomes for everybody in an equitable way. About almost 2 decades ago, we undertook a Health Research Council funded qualitative study that indicated quite clearly that Maori and Pacific families, compared to Pākehā families who had children admitted to the Starship and Kids First, had rather different experiences of engaging with services, particularly after discharge from the services. And when I have presented this work in other parts of the country and say, well, this probably doesn't happen in your part of the world, what do you do? Right, almost everybody says, we have no idea. It's not that it doesn't happen anywhere else. And I think as one of the caregivers, actually, Bridget was one of the informants, I think, was interviewed for this. As a service provider said in the service provider part of this study, I think a lot of children are going home with parents who are still in that traumatic time themselves. I think we're not assessing, not asking those questions. How is it going to be for you in terms of managing? We ask the physical ones, like, can you manage this child getting to the toilet, but we don't do such a good emotional stock take. So I'm basically working with Dr. Braden Teao, who's a health economist, a Maori health economist, Dr. Jamie Lee Rahiri, who's a surgical postdoc now, registrar, Marita Hunt from the Starship, and a group of others to really develop a pediatric trauma outcome study for New Zealand. Because we're doing this for adults. The National Trauma Network is following up adult trauma, major trauma patients, but not kids. I think we want to do this, but do it in a way where we're going to get the kind of information that can lead to the sorts of services and actions that I think will hopefully leave no child behind. So I want to leave by acknowledging particularly Professor Belinda Gabby, who is the lead for the Restore project in Melbourne, and invite any questions you might have, particularly suggestions for the study that we think we need to do in New Zealand that particularly considers equity and treaty responsiveness and avoiding the kinds of traps we might otherwise have. Thank you very much.